Good afternoon. I'm Dr. Deepan Shah, head of the Division of Cardiovascular Imaging at Houston Methodist Hospital and director of the Cardiac MRI Laboratory. It's my pleasure today to speak with you about basics of cardiac MRI. So let's start off with, here's a picture of one of our MRI scanners. This is actually one of our inpatient scanners. Um, Advantages, obviously, of MRI. It's a non-invasive technique, does not require ionizing radiation, is able to produce, as I'll show you, very good quality images by using high magnetic fields. And with the MRI technology, for cardiac purposes, we can really now do imaging for a variety of different indications, as is shown by this schematic here, whether it's assessing cardiac masses, looking at stress perfusion in patients with ischemic heart disease or suspected ischemic heart disease, assessing myocardial flow, assessing for constriction, importantly assessing myocardial viability, and then also assessment of valvular heart disease. So let me take you back in time a few years, a few decades maybe, to these two gentlemen right here, Peter Lauder and Sir Peter Mansfield. So these are the two Peters that really were jointly responsible for the initial discoveries concerning magnetic resonance imaging that have progressed to where we are today. And in fact, they received the Nobel Prize for this in 2003. And the very first image they obtained was actually a cross-sectional image of a finger using MRI technology. And the acquisition time, 5 hours. So we've come a long ways away since then. And so I'm going to pose a question to the audience, which is, when was that first human MRI experiment or imaging session performed? Raise your hand if you think it was 1969. The year we landed on the moon. Okay, raise your hand if you think it was 1980. Okay, with a couple people. And raise your hand if you think it was 1977. A couple people voted twice. So, in fact, it was 1977. But to give you an idea, from the time they did that initial acquisition to show proof of concept with this MRI technique, until the time they received the Nobel Prize, which was when 2003, many years transpired. So again, for those of you that are actively engaged in research, recognize oftentimes it takes time for the full value of your research to be fully recognized. These individuals right here, it took them almost 4 decades, but then eventually led to a Nobel Prize. So it's not a bad final outcome. So next question is, when we're doing MRI imaging in humans, what is the most important element with regard to MRI imaging? Is it oxygen, hydrogen, or carbon? Again, let me get a poll from the audience. How many of you think that the most important element for the purposes of MRI imaging in humans is oxygen? Raise your hand. Okay, nobody. All right, how many thinks it's hydrogen? Raise your hand. Almost everybody. And who thinks it's carbon? Nobody. Okay, so everybody got it right. That's excellent. So hydrogen is in fact the key element when it comes to MRI imaging. And part of the reason for that is because in humans today, for clinical purposes, and part of the reason for that is because the body is made up almost 2/3 of water, hydrogen atoms. So that gives you the best signal. Now you can do imaging with a variety of other elements as well. It's just that the amount of signal you're going to get is not nearly as robust because again, the human body is made up primarily of water. And so to do MRI imaging, really there are kind of 2 basic things that you need. You need a magnet, you need a magnetic field, and you also need radio waves. And I'll talk about how we utilize this, but we have radio waves that are transmitted and radio waves that are received in conjunction with a magnetic field, which really then ultimately allows you to be able to generate an image. Now, there's many steps between these 2 basic elements here and actually generating this image that we see on the right-hand side. And what we're going to do today is go through a little bit and talk about some of the basics of MRI physics, how MRI technology works. And then, importantly, really talk about MRI safety aspects, talk about special situations like patients with implanted devices, can those be done or not, talk about gadolinium contrast, And then if we have time, we'll just wrap up again with kind of an overview of clinical applications of a cardiac MRI. So let's talk about the MRI system itself, all right? And so really you want to think of it that there's three basic components to this MRI system. There's the main magnetic coils. So that's kind of this, if we look at this bore right here, this big, huge donut type, that's what has the kind of the static magnetic field. There's also within that something called gradient coils, and the objective of gradients are to cause a local alteration or distortion to the magnetic field. And then there's radio frequency coils. And radio frequency, there's transmitter coils and there's receiver coils. And so we'll go through all of this in more detail here. First, another question for the audience. So what are the typical magnetic field strengths that we use for clinical MRI imaging? How many of you think clinical MRI imaging today can be done at 1.5 Tesla? Raise your hand. So most of you don't think it can be done at 1.5 Tesla? This is an easy one. Everyone should raise their hand, okay? Most clinical imaging is done, in fact, at 1.5 Tesla. What about 3 Tesla? Can we do imaging at 3 Tesla? Yes, we can, right? What about 0.5 Tesla? So this, if I gave this lecture 10 years ago, the answer would have probably been no. There's no clinical indication for, or clinical use for 0.5 Tesla. There now is approved 0.5 Tesla scanners. And in fact, there are sites that are working on cardiac imaging with that. What about 7 Tesla? I mean, this actually is a picture of the 7 Tesla MRI scanner that went in our research institute building about 10 years ago. This is actually how they were installing it. So in fact, 7 Tesla can be used for clinical imaging, not really for cardiac imaging though, because there's specific nuances for cardiac. And so it's primarily indications are going to be brain or orthopedic indications. But really, you've got a variety of different field strengths. Sorry, let me skip forward here. Today that you can utilize. Now, there are MRI systems that are even stronger. There's 9 Tesla, 11 Tesla, but those tend to be very small bore and not really for human use per se. And those are more for research applications. So we talked about the main magnetic field, and we talked about 1.5 or 3 Tesla is kind of predominantly the field strength that we utilize. And to give you an idea of what that translates to, we all know that the Earth has a magnetic field as well, right? If you ever have a compass, right, you can see that. But 1 Tesla represents about 20,000 times the Earth's magnetic field. So when we're talking about 1.5 or 3 Tesla imaging, we're talking about a fairly strong magnetic field. Now, the other element is the gradient coils. And so the gradient coils are within this MRI system right here. And the objective of and also the gradient coils exist in all 3 anatomic planes, so in the X, Y, and Z axis, right? And the reason for that is that then allows you, with MRI, to be able to image in any imaging plane that you want. So you can do a straight axial imaging plane like we do with CT, but you could also do a coronal or sagittal, or you can do an off-axis plane like a short axis or long axis view, the cardiac imaging planes that we utilize. And so that's a foundational strength, I think, of MRI compared to, for example, other cross-sectional imaging techniques like CT, where with MRI, you can pick any imaging plane you want. With CT, you can only acquire the axial plane, and then you can then reconstruct stitching those images together to different planes. Now, so the gradient coils, as we talked about, they're within that MRI scanner itself. So they're encircling the body. And the purpose of the gradient coils are really to cause a distortion or an alteration in the magnetic field. But it doesn't do it in a random fashion. It does it in a very specific manner, such that as you apply a gradient, if we apply it, let's say, in the head to foot direction, then with the application of the gradient, instead of the local magnetic field being 1.5 Tesla, it may be slightly higher as you go further away from the center, closer to the head, and it may be slightly lower as you go further away from the center, more towards the feet. And so again, we're talking about small magnitudes of changes. So instead of 1.5 Tesla, it may be 1.500001 Tesla as you move further to the head, and just a little bit lower as you move further to the feet. But again, as you get further and further away, the alteration in the magnetic field gets more and more and more. That's important to recognize because when we worry about from a safety standpoint, things like stimulation, peripheral nerve stimulation, when you have alterations in magnetic fields or gradients, that's going to occur predominantly at the periphery. So that's going to occur at the edges of your scanner. Okay. The last piece then is what we call radio frequency coils. And so that's the radio waves that I talked about. So remember in the very first couple of slides, I talked about the basic elements for MRI imaging is a magnet or magnetic field and radio waves. So these radio frequency coils, there's two types. There's transmit coils. So these are actually within the scanner itself. And there's also receiver coils. So the transmit coils send in radio waves. The receiver coils are listening coils that listen to receive back radio waves. And the listening coils are present both within the scanner itself, we call the body coil, and then they can also be present within surface coils that you'll place on top of the patient. So for those of you that have been to the MRI suite and you've seen a patient in the MRI scanner, you'll see that there's oftentimes these little coils that we put on top of the patient. So we put them on the chest, or we have them on the spine behind the back. And the purpose of these coils is really to be able to receive signal. But the advantages are that they're closer to the body where the action is happening versus the coils that are within the magnet itself, which are further away. And the reason for that is that it's just like with the radio wave, right? I mean, how many of you, most of you probably only listen to satellite or listen to your phone when you're in the car or listen to music. But if you ever listen to the actual AM or FM stations, right, as you get further away, if you're doing a long trip, right, as you get further away from the big city where the station is transmitting the radio waves, you gradually start to get less and less signal, and eventually, it gets kind of noisy, and then eventually you don't get the signal at all. That's the same thing. If you're further away, you get less signal, you get more noise. And so that's part of the reason why we use these surface coils, which are right on top of the body, because they're as close as they can be, so they're going to pick up more signal and less noise. Okay, so this is just an example of a patient. This is what I call a total body coils, where this person has got a coil up in the head. There's a series of surface coils that are on the chest, and then there's actually coils that are also down all the way down to the legs as well. So, for most cardiac imaging, you don't need all of these coils, right? You just need the coils around the heart. But where this is useful is, let's say if you're doing a vascular runoff study, where you want to look at the thoracic aorta, abdominal aorta, and lower extremity arteries, then obviously you need coils all the way down, because if you try to image without these surface coils, you're going to get much more noisy of an image. Okay, so that's the basic hardware. Let's talk a little bit about kind of the physics of what happens with MRI imaging. And again, you'll notice I've got a lot of kind of physics topics, but I'm going to try to get through the physics in about 20, 30 minutes, so then we can turn our attention more towards clinical aspects, which I think will probably excite people more. But one of the things to keep in mind is that so we're talking about hydrogen atoms or protons, right? Because again, majority of what we do for clinical purposes is hydrogen-based imaging. If you take a glass of water, for example, which obviously has a lot of protons, right? Hydrogen atoms, the protons are spinning around in a very random fashion. They're all over the place. So as a result, you have zero net vector. What happens is when you move it into a magnetic field, the hydrogen atoms then line up in the direction of the magnetic field. And so some of them will line up in the positive direction, and then some of them will line up in the negative direction, but they'll line up in the direction of the field. And you'll have more protons that are aligned in the positive direction versus the negative direction, giving you a net magnetization vector in the positive direction. Okay, that's a basic kind of principle. Is you take hydrogen atoms, you put them into a magnetic field, they're going to line up in the direction of the magnetic field. Some will be parallel, some will be anti-parallel. All right, and obviously parallel means that they're lined up upright. That's a low energy state, and when they're lined up upright, they also are spinning around as well. Right, they do what's called precession or spinning around. So that's just an inherent property of hydrogen atoms in a magnetic field environment, is that they'll line up. Some of them will line up in the direction positive, some will line up negative, but a net excess of positive, and they'll continue to spin around or precess around. The negative direction is a higher energy state, the anti-parallel direction. And the amount that line up, you can see in this schematic here, there's 3 that are positive, 2 that are negative, so you have a net vector of 1 positive, right? The amount that line up positive, the net excess, is directly related to your magnetic field strength. So if you go from 1.5 to 3 Tesla, then instead of having a net excess of 1, in this, just example, conceptual example, you'd have 2 protons that are lined up positive versus two more that are lined up positive versus the ones that are negative. So the idea is as you go to higher field strengths, you have more protons that are lined, and that's part of the reason why you get more signal when you go to higher field strengths. Now, let me skip past this. The other aspect to this is that they're spinning around, right? Whether they're upright positive or they're anti-parallel negative, they're going to be spinning around. And the frequency that they spin around at is actually a predictable frequency. And this actually is very important for anybody that, any of the MRI fellows, if you're planning on taking the MRI board exam, I would be very surprised if this didn't show up on the board exam, right? And it's this equation right here, which is called the Larmor equation, all right? And what it basically says is that when you put protons into a magnetic field, the frequency that they spin at, this precession frequency, is equal to a ratio called a gyromagnetic ratio multiplied by the local magnetic field, by the magnetic field strength. And so that means then that ratio is specific to each element. So for hydrogen elements, that ratio is 42 megahertz per Tesla. So you take that 42 megahertz per Tesla, and if we put it into a 1.5 Tesla scanner, then somebody do the math. 42 megahertz per Tesla is a gyromagnetic ratio for hydrogen. Multiply that by the magnetic field strength, and that gives you the precession frequency. So at 1.5 Tesla, what does that come out to? Say it. I'm hearing the answer. Somebody say it loud, please. 64. So 64 megahertz at 1.5 Tesla. Now what about at 3 Tesla? 128. So see, if you know the equation, the math becomes very simple. And again, the nice thing for the fellows taking the boards, the exact, I gave you simplifications. The exact number is a slight offset of these numbers, but fortunately on the boards, they're not going to get you down to the 0.001 level, right? So if you just kind of have a general understanding that multiply 42 by the field strength, that gives you the frequency that it's spinning around at. Okay, now let's talk about MRI excitation. So this basically says that the protons are lined up with the magnetic field and they're spinning around. And again, that's the low energy state or the resting state that they go to when they're in a magnetic environment. What happens now if I apply a radio wave? Remember in the very beginning I talked about a magnet, magnetic field, and radio waves. So now we're talking about the next part, which is what happens when I transmit, I send in a radio frequency waves. Well, what happens is those protons absorb that radio frequency wave. Some of the protons do, and we'll talk about which ones do. That energy then gets transmitted from the radio wave to the proton itself. And that transmission then results in what we call excitation. And excitation means that instead of them spinning around in the upright position, which is the resting state, they get tipped over. So it's the same thing. If I had one of you and asked you to stand up here, in the resting state, you'll be standing up nice and straight. If I push you, you're going to tip over, right? Now, how much you tip over depends on how much I push you, right? If I push you really, really hard, you might tip over all the way so that you're now in the flat on your face on the ground, which is basically a 90-degree push, right? Which means I've taken you from being upright to being completely flat. And obviously, though, you don't have to do all the way to 90. You can do 40 degrees. Or, in fact, you could do more than 90, right? Again, it's just about the amount of energy that you give. And the way that this radio frequency wave is given, there's 2 factors that affect how much you cause it to tip down. It's the amplitude and the duration. So again, same thing. If I have one of you here, if I push you really, really hard, just for a short duration, but it's a very hard push, you'll go down. Or I can push you slower, but I can keep pushing you, and I may wear you out, and you may fall down as well, right? So it's the amplitude and the duration that determines how much you cause those protons to get tipped down. And what we typically do is refer to that as a term called alpha. All right, that's the alpha angle, which is based on whatever specific radio frequency pulse you apply. This is how much of a net perturbation or how much of a push down you're going to get. All right, so let's go to, let me skip past this here. And so what this concept brings up then is, as I cause excitation, as I cause the protons to be moved over, I then will get more component now in the transverse plane. So remember, in the resting state, it's upright. The amount that's in the transverse plane, which is again on the y-axis here, was 0. But once I apply a radio frequency wave that causes it to tip over a little bit, now I've got some of my magnetization has now been transferred from the longitudinal plane, the upright plane, to the transverse plane. Now if I do a 90-degree tip, then I have 100% of the transfer of magnetization. So whatever magnetization I had in the longitudinal plane, all of that goes into the transverse plane or the horizontal plane. If I do a 45-degree, then it's a percentage of that, all right? And again, you can choose whatever angle you want, anywhere from 1 to 90. And again, we'll talk about you can even go more than 90. But the net effect of that is you lose magnetization in the transverse plane, and you gain, or in the longitudinal plane, and you gain magnetization in the transverse plane. Okay. And then obviously, the one that gives you the highest signal in the transverse plane is the 90-degree, right? Because that way you're taking all of that longitudinal magnetization and transferring it over to the longitudinal plane. So this is an example. Watch through this, let this cycle through again, right? You apply an RF pulse that causes it to get tipped down. Now notice, even though we're doing a 90 degrees, so the protons now, instead of being upright, they're in the horizontal plane, they still keep spinning around, right? So precession or spinning keeps happening all the time. Whether they're upright, they're going to spin, or whether you put them into the horizontal plane, they're going to spin, or if you do a 45, whatever radio frequency pulse you apply, they're going to still keep spinning around. Okay, so now let's talk about two other concepts, which is T1 and T2. Now, how many of you heard of this terminology, T1 and T2? Okay, I bet you most of you heard of it. I mean, even in internal medicine days, you hear about T1 and T2 weighted imaging, right? Even in medical school. So, but let's talk a little bit about what it is. So one is MR relaxation. So that's T1, okay? So it's not going to the beach and relaxing. It actually is the fact that when I apply a radio frequency wave, the natural tendency then is to go back upright again, right? So notice they're starting in the upright plane. I applied a radio frequency pulse to cause it to tip over, whether it's a 45-degree or 90-degree tip or whatever. What's going to happen then, once I stop applying that radio frequency energy, then it's going to try to go back up into the resting state. So that's the relaxation, right? And so if I apply a 90-degree tip, as I talked about before, the longitudinal component is 0, right? And then what happens as time goes by, well, that longitudinal component will regain itself, okay? And then over time, we'll be back to 100% again. And the same thing, like if I took any of you and I pushed you over and I knocked you down on the ground, you'll be horizontal for a few seconds, but then hopefully you'll get back up, right? And eventually you'll get back up and you'll stand up again, right? And so the T1 time is just the amount of time it takes to regain or to regrow back to 63% of the 100% state. So if you're 6 feet tall, I knock you over, how long does it take for you to get back, start to stand back up again, to get back to 63% of the 6 feet tall you were originally? That's what T1 time is. So that's, again, you just have to memorize that. The boards like to ask a question like that. And then there's obviously, in more detailed lectures when we talk about in the MRI conferences, we'll talk about exactly what causes these things. But for today's purpose, I think just recognizing that T1 is a recovery or relaxation, and it represents the amount of time to regain back to 63% of the full resting state. Okay, and so shorter T1s mean faster T1 relaxation. Longer T1 times mean slower T1 relaxation. And this characteristic T1 is tissue specific. So each tissue has a certain inherent T1 values. So fat, for example, as you can see from this curve right here, does fat have a short T1 or a long T1? I.e., does fat have very fast recovery or slow recovery? Was that fast, right? So you can see this right here. And in fact, if we measure the time it takes for it to get back from, you knocked it down to 0, and then starting to regrow again, the time it takes for it to get back to 63%, that's a T1 time. So for fat, that T1 time is on the order of about 200 milliseconds. Okay? Compare that to water, right? What is a T1 recovery for water? It's slow. So the amount of time it takes for water to get back to that 63% can be over 2 seconds, 2,000 milliseconds. So myocardium is somewhere in the middle. And then infarct, especially if we give gadolinium contrast, right? So anything that causes gadolinium to be concentrated within it will have the T1 time shorter because gadolinium causes shortening of the T1 time. So we'll come back to gadolinium and how it works a little bit. But again, just understand these basic principles. And then the other thing to keep in mind, this is a separate process that's happening at the same time. So we talked about the fact I knock you over, you eventually will start to come back up again. Well, the second piece is that, remember I talked about the protons are spinning around, so even if I knock you over into the horizontal plane, the protons are still spinning around. It's just that they'll gradually become what we call out of phase with each other. A simple analogy I like to think of is, those of you who've seen the Rice track and field track across the street, right? There's a nice track that goes all the way around, right? There's a quarter-mile track. What happens is if we take all of us and we put us on that track and we say go, we're all going to, and we look up from our Smith Tower office on the 18th floor, all of us will look like a big blob all together at the starting line, and we'll all start running, right? And what will happen over time is that some of us may be faster than others, right? And what if we get, Michael Jordan is one of my favorite athletes, we get him on the track. Well, he's going to be going way faster than the rest of us. So if we wait a little while, we all start to separate out, right? And if we look up from the top, what we'll gradually see is that big blob where we saw everybody together gradually separates out. And over time, everybody will be all randomly distributed across the track, after multiple cycles. And as a result, then there'll be no net signal or no net vector because everybody will be randomly distributed, right? So over time, that's what happens with these protons as well, is they gradually start to get out of phase with each other. So again, you gradually lose the transverse signal. So that's a basic principle, is that you regain the longitudinal or the T1, you lose the transverse, right? Because when I tipped it over, you took all of that magnetization into the transverse plane, but gradually then it'll go away. And that is shown in this schematic right here. As you tip it down 90 degrees, look what happens. The runners all start to separate from each other, and over time, they start to get further and further apart. Eventually, they'll all just be randomly distributed across the track, so you have no net vector. Okay, so this now is what we call the T2 relaxation time, or T2 decay time. And so what's happening here is, in the beginning, there's a full vector, and then gradually over time, it becomes less and less and less. The rate at which this decay occurs, the T2 time is defined as the rate at which you get down to 37% of the original magnetization. So you start, because once you tip everything over, you're starting at 100, but it starts to again separate out, and once you get down to 37%, that's your T2 time. So T2 is also tissue specific. And so something like fat, which we talked about had a very short T1 time, notice also has fairly short T2 times as well. And in fact, if I look at the signal for fat, the decay curve, you can see that for fat, the decay curve such that by the time it gets to 37% is only about 100 milliseconds, right? Whereas water has a much slower T2 decay, it takes a much longer time, so the time that it gets down to 37% may be on the order of 1,000 or 2,000 milliseconds. Okay, so if we know that different tissue have different inherent properties, you can then do an MRI imaging sequence that's designed to amplify T1 properties or amplify T2 properties. And that's what I'm showing you here. And so if I do a T1 weighted acquisition, then we talked about the fat, which has very quick T1 recovery, will have very high signal. Okay, whereas water will have low signal, almost appears gray or dark. Versus if I do the same exact location, so I'm imaging the exact same structure, but I'm using a T2 weighted acquisition, then notice the water, in fact, has very high signal, whereas the fat, we've done something else also to suppress the fat signal, would have lower signal. So the point is, if I show you an image and say, okay, tell me what's the composition of this tissue, first thing you should ask me back is, well, what sequence is this? What are the parameters that you use? Is it a T1 weighted acquisition or a T2 weighted acquisition? Because I can make the exact same thing appear different. I can make it appear bright, or I can make it appear dark, depending upon the specific imaging sequence that I utilized. And so again, that's where I think it's unique compared to most other imaging modalities. This is what we call kind of the tissue characterization properties of MRI imaging. Okay, so now we're getting through some of the basic physics. I'm going to talk a little bit about how you make an image, and trust me, you make beautiful images with MRI. And then we'll really talk about clinical applications. So hang in there. We're in the eighth inning so far. So there's three things that you need to recognize. There's slice selection, there's phase encoding, and there's frequency encoding. And so let's go through this. Whoops. Slice selection basically means what slice do I want to image? And one of the nice things is, in the echo lab, for example, sonographers got to move the cursor, move the probe to try to get the specific slice or imaging plane they want. In MRI, it's very easy because you just move the mouse to the location that you want. You just draw a line. And so the way that the scanner then determines the specific slice that you're interested in imaging is it says, okay, if you told me you want me to image at this location right here, I can apply a gradient at which the protons or the magnetic field further away is going to be higher than 1.5 Tesla. And on the opposite side, it'll be lower, but right at the center, it'll be exactly 1.5 Tesla. And if I send then a radio frequency wave that corresponds exactly to 64 megahertz, then only the protons within the slice will get excited. So only those protons will absorb the radio frequency wave. The protons up in the head, the protons up in the feet won't absorb that radio frequency wave. And so that's what's called sending in a slice selective pulse to select the slice that I'm interested in imaging, right? And any of you, if you have kids, I mean, you know this, if you take them out on a swing, right? If you're synchronized, so you're pushing them, when they're coming back to you, you push them again, you're going to transmit your energy to the swing and you're going to make them move up, right? But if you're off sync with them, if you're pushing at a different rate that the swing is going, guess what? You have no effect at all, right? That swing doesn't see any of your pushes, and so it's completely negligent to those. So again, it's only the frequency of radio waves that you apply will get absorbed by the protons that are spinning at that same frequency. So it's a way to be able to select the slice of interest. The next piece, this one's a little bit more complicated because this is what we call the phase encode and the frequency encode. And the idea here is that not only when you cause excitation, a specific slice of interest will get excited, but then that slice will eventually transmit the signal back. It'll as it recovers again, those protons send a radio frequency wave back, and they send a series of different radio frequency waves. That information can be used to then encode where those protons were within the frequency direction. And then the last piece is what we call the phase direction, where you apply a magnetic field for different durations multiple times. That causes protons to spin it slightly, or to kind of get offset from each other a little bit more or a little bit less. Again, going back to the running analogy, right? Depending upon how long I let people run for, right, we may start to separate from each other, and we're using that information to help us encode in the phase direction. So that concept is a little bit more complicated, so I gave you just a simplification of it for the interest of time. If anybody's interested in more details, come to the MRI conferences and we'll dive into this in more detail. But collecting that information about the phase and the frequency allow us then to actually generate an image, but there's one step that you have to do before that, which is you plot the phase and the frequency information and then do what's called a Fourier transformation. That Fourier transformation then is what actually allows you to produce an actual image itself. So again, this is kind of a complex mathematical approach. We don't need to get into specific details of it now, but there's a couple of basic principles that I think are important to recognize with this approach, which is that every single line that you acquire somehow contributes to the image. It's just that some lines contribute to the information about image contrast, and some lines contribute to the information about image details. okay? And so if you look at it here, the center lines of K-space, right? So this is all of my K-space, which is, again, just a plot of my phase and frequency direction with all of these different samplings that I do. The center lines give you information about image contrast. So I can see some things are brighter than other things, but I don't have very fine details. The peripheral lines are what give you the fine details, but they don't give you anything about the image contrast. But obviously, if you take all of those together, the peripheral lines and the center lines, that's what then gives you an image where you have both fine details and you have different information about image contrast. Okay, so you may be a little stressed right now. We're going to de-stress, all right? So let's come back. This is the slide I showed in the very beginning, right? Again, at the end, all of that physics stuff that's happening in the background, the objective is to really be able to generate these images, right? Because these images are what help us take care of patients. So if you're first-year fellow and you're seeing a bunch of consults on the floor, well, this is going to help you to say what's going on with this person's heart. Or if you're second-year fellow and you get to see patients in a more leisurely clinic setting, same way. It's trying to understand what's going on with a given patient using these different MRI techniques. If you look at it, if we look at, this is some data published in Radiology Cardiothoracic Imaging a few years ago, which really showed that if we look at this is Medicare data, the number of echo studies that were done over the last couple decades, you can see that they've been pretty flat. The number of stress SPECT perfusion studies actually have been going down. But what you notice is that there's an increase in PET, CT, and MRI. And again, part of the reason is because you're starting from a lower base. Part of the reason as this technology gets more disseminated, and part of the reason is as we're learning more and more useful indications, more and more patients are getting these advanced imaging technologies. So I think for the general cardiology fellows, you may say, I'm never going to do MRI. I have no interest in doing imaging. Well, you're going to have to still understand these advanced imaging modalities because you're going to likely be using these in your practice. So even if you're going to a smaller town and you're not an imaging specialist, you're going to need to be able to interface with your imaging specialist. Oh, what is it doing? It's giving you the preview here. Okay. I didn't realize it was you guys were knowing what I was going to talk about next all along, weren't you? Okay. So one more thing. Right here. This, I think you need to recognize. There's a saying I always say, the magnet is always on. What that means is that Sunday night, the scanners turned off, or the scanners, all the lights are out, nobody's around. The magnetic field is still there, right? It's still, if it's a 1.5 Tesla, it's still a 1.5 Tesla magnetic field. That doesn't ever get turned off, right? So as a result, you cannot take some metallic object into the room, right, without knowing what it is. This is an example, not from here, but where somebody, thought, let me take this bed. It's probably after hours and they're cleaning up and, let me move this bed. What happens is a metallic object that's ferromagnetic will get pulled to the magnetic field. And the magnetic field, as you get closer and closer to it, gets exponentially stronger. So it can take an entire bed like this and it can just pull it in, all right? So the point is, where it's important is if you guys ever get called for an emergency in the MRI suite, you do not go into the room. You tell the technologist to bring the patient out. And we always tell the techs, if there's an emergency, then don't worry, don't take your stethoscope, don't take the CPR cart. You get the patient out of the MRI room, put them into the recovery area, and then let the code team come and address that. And that's why, from a safety standpoint, we have kind of a zoning nomenclature as well. So there's zones 1 to 4. Okay, so zone 4 is the most restricted access area. So that's the room with the MRI scanner itself. All right, there should always be either a keypad or a badge access to be able to get in. So nobody should be able to just go and open the door, right? It's got to always be locked, and you have to have special permission, right, whether you have badge access or the specific code to go into that room. And so again, for the vast majority of you in this room, unless you're specifically rotating in the MRI laboratory, you should never go inside this room unless you're invited to come in, okay? Sometimes we'll invite you guys to come in to show you something, but we'll check to make sure you've taken everything out. And the things you worry about, I mean, my glasses are probably fine. Glasses are fine. You have to look at what you're taking into the room and what the metallic components of it are. And recognize there's some things that are ferromagnetic, which means they'll get pulled to the magnet. There's other things also, though, that could get affected by the magnet. And obviously, what's the most important thing that you have on you that could get affected by the magnet? Well, the stethoscope will get pulled, right? Because the stethoscope is ferromagnetic. It's credit cards, okay? A good example, I'll out him. Dr. Little, when I first came here, he volunteered, and he kept his wallet with him. And he went shopping that weekend, and his wife's like, "Why is everything getting declined?" You know, because it's a magnet, so it gets deactivated, right? So if you take anything that's magnetic, it's going to get deactivated inside there. So one is, from a safety standpoint, don't take, like a stethoscope you would not want to take into that room. Don't take anything that's ferromagnetic that'll get pulled by the magnetic field, but also anything that has a magnetic stripe will get deactivated, okay? So that's zone 4. You should not go into zone 4 unless you're invited to go into zone 4. Zone 3 is the area that's directly outside of zone 4. That's a control room. So if you've ever seen the tech scanning a patient, that's zone 3 right here. This is also controlled access. So you can't, nobody should be able to just wander in to zone 3. And then the next zone is zone 2. So this is within the MRI suite itself, but it's a public access area in the sense that this is where we meet patients. So this is where the reception area, right, where the patient comes in to check in, or the holding area where the nurse, puts a patient into a gown, checks the vitals, does the metal screening. All of the screening will happen here in zone 2, so that nobody goes into zone 3 without being screened, and then definitely not into zone 4, okay? And then obviously zone 1 is just the entrance, so that's a very safe area, so that's not a controlled access area. Okay, so we already talked about the fact emergencies, do not go rushing to the patient, let the patient come to you, and again, you wait in the holding area, okay? Don't go into any area that's a controlled access area. Next is, let's talk about terminology. So people always like to ask me, hey, is this MRI safe, is this MRI unsafe? So that used to be an old nomenclature that we used to have. Nowadays, the FDA kind of uses a tripartite nomenclature. There's MRI unsafe, MRI safe, and MRI conditional, okay? So MRI safe is something that in any scenario is safe to take into the MRI environment. That's like a petri dish, like a plastic, right? MRI unsafe is something that we know definitely cannot be taken into the MRI environment. That bed you saw, that's definitely MRI unsafe, okay? Most devices that we use today are what we call MRI conditional. And what that means is not that it's a blanket, you can take it into the MRI, it's that we've tested it in a variety of scenarios, and in this series of scenarios, it's considered acceptable risk, all right? And this gets to the concept of risk. I'm gonna talk about that in a second. Know now that most of the pacemakers and defibrillators that are implanted today, or at least almost all manufacturers have MRI conditional pacemakers and defibrillators. Now, what are the concerns with MRI devices? Obviously, there's several things you worry about. One is heating. So if you have metal, when you apply these radio frequency waves, could that metal absorb those waves, and could that cause heating? And if the device heats, you may say, well, what's a big deal? Is it going to malfunction? It's not so much about that. It's could it then cause heating of the tissue in the human body around the device? The other is obviously mechanical effects. Could this device move? So I implanted something, could it move? All right, and then the third would be electromagnetic effects, where it causes an electromagnetic field itself. That could cause problems, where it could cause excitation to the patient, or it could cause pain. So these are things that you need to be aware of. Obviously, they're affected by a variety of different things. Some of it's based on the device or the structure itself. Some of it's based on the location, where it's located within the magnetic field, and some of it's based on the MRI the sequence that you're utilizing. So there's many, many possible permutations to that. So all you really need to do, if you're on the floor with a patient, is just tell us that the patient has a device. We'll go through and figure out, can we manage to do this? Nowadays, we've developed an approach where almost all implanted cardiac devices we can do. But we need to know about it first, so we can say, okay, let's understand what this device is, where is it positioned, and then we modify the way that we do the acquisition, both from the standpoint of reducing artifacts from the device, but more importantly from maximizing safety, okay? And in fact, there's a couple publications that came out in New England Journal. We were involved in the one on the left-hand side here, which looked at several thousand patients, each of these series, and really kind of try to quantify what is the risk. And these are with the non-MRI conditional pacemakers and defibrillators, so what we call the legacy devices. And so that's why I say now is we've got lots of experience with this, and we're comfortable with scanning patients that are not labeled as MRI conditional, but we need to know about it beforehand. And here's why, and this gets to this issue of safety. Now, how many of you have been to Las Vegas? Okay, this is not being recorded, so don't worry about it. Just tell it. Only one of you or two of you? Seriously? Or you just don't want to admit it? Okay. Maybe you've seen pictures of Vegas, right? It's a beautiful skyline. There's a hotel there called the Vidara Hotel. Most of you heard of that? In that kind of city center area? It's a very nice, ritzy hotel. It was built around 2007 or 8, okay? I mean, multi-billion-dollar building. Shortly after it was built, a year or two later, there were these concerns, okay? I'm gonna...
Taking a road trip to Vegas, be warned. The new MGM hotel there called the Vidara has been found to contain an extra you definitely don't want. It turns out when the sun's rays hit that curved building, it creates a 15-foot wide hotspot on the ground that is so brutal it can burn hair and skin and even melt plastic. Some unlucky hotel guests have been sent running from the pool area after being caught in what hotel employees are calling the death ray, a burning sensation from above. The hotel is rushing to fix the problem.
The promise fixed, so don't worry about it. You can feel free to go there. What was happening? So remember you saw the building was all glass, right? And it was a nice circular, right, semicircular building. So what happened is during a few days in the year, during a certain time of the day, it just happened that the sun's rays were coming in and they were all getting reflected in such a manner that they all get transmitted to a very small central area in the pool, okay? A 10 by 15-foot area. So again, 350 days out of the year, this doesn't happen, right? It's only certain days when the sun's position is such, and it's only a certain time of the day, and obviously if you have a cloudy day, it's not gonna happen, right? And the point of that is when we talk, and that's why also when we talk about how we label a device, we don't say MRI safe or unsafe. We say it's conditional in the sense that there's a series of scenarios that we've tested and we've shown at least that reasonable safety. It doesn't mean you can't possibly think of every possible scenario. The other thing is you can't possibly test every possible scenario. One of the things that you can do, and this is where I think we're using kind of computer technology helps us, is they can model a variety of scenarios. So they can say, okay, let me model what the sun's rays would be like in January, in February 2nd, February 3rd, February, right? Because you can't sit there and sample, all year long and sample also for cloudy days versus non-cloudy days. So this is where the FDA utilizes modeling a lot with these devices to say, let me model a variety of different scenarios and say, okay, in this variety of different scenarios, we don't think that there's a risk. It doesn't mean that there isn't, right? That's the other thing I think is important to keep in mind. It's just like you all have a driver's license to drive. That means that you're acceptable risk to drive. It doesn't mean you're not going to get into an accident, right? It can happen, and it can happen because it's a variety of different conditions that can happen. So it's the same thing here with all these devices that we do. We come up with a way to mitigate the risk by understanding what the potential risks are. But at the end of the day, you can never completely eliminate it, and you can never completely test for all possible scenarios. Because what if a patient's got a defibrillator, but they've also got some other, hip implant, or they've got, there's so many possible permutations that you can't possibly actually test for. So what you can do is you can go to websites where you can look it up. So the FDA has now, for most devices that get approved, it's part of the package insert, what its MRI safety profile is. So, again, on the floors, you guys don't need to worry. If you want to, you can. But if you just let us know what the device is, then we'll look it up, and we'll kind of find out, okay, this one cannot be done, or this one can be done, but we need to, modify the protocol, the way that we do the acquisition, whatever. I mean, there's lots that go into the scenes behind how we determine how to modify it. But we can't do that without knowing, right? And if you look at it, the concern with implanted devices, the reason why people said, oh no, we couldn't, for a long time we didn't scan people with pacemakers and defibrillators. And if you look in the literature in the 90s, there were cases of deaths. People that had a pacemaker and went in and got an MRI scan and died, right? And so obviously what caused those scenarios, if you look at all of those cases, those are cases where nobody knew they had a pacemaker, right? They forgot to tell the lab that they were getting that they had a pacemaker in place. And these are mainly radiologic scans where if you've ever gone to see somebody getting a knee scan or a brain scan, they're not doing rhythm monitoring throughout, right? I mean, you go in and they get a brain scan, there's no monitoring that's done necessarily, right? Whereas for cardiac scans, we have to inherently monitor your cardiac rhythm because we have to know how to do the acquisition to work around your cardiac rhythm. So part of it is, again, if you don't know they have a device, you put them in the MRI environment, the pacemaker can get fooled into thinking that all this MRI activity is actually the patient's intrinsic pacing. So this pacemaker may say, oh, I don't need to pace because, oh, there's all this, the patient's already got his own intrinsic activity. In fact, it's not the patient's intrinsic activity, it's just the external MRI activity that it's sensing. So again, the point of this is you need to know, and then you need to modify the protocol, you need to reprogram the device many times, and you need to monitor the patient throughout. But as long as we do those things, I think we can, in an acceptable manner, scan most patients with implanted devices. Next, let's turn to gadolinium contrast. So, we use gadolinium contrast quite frequently. I would say probably 95% of the time in cardiac MRI. And we use it because it has an inherent property, which is it causes T1 shortening. So it takes the T1 time from 500 milliseconds to 250, or whatever you're starting with as the baseline T1 time, it shortens it. And the magnitude of shortening that it achieves is based on the amount of gadolinium contrast that you're giving, or the amount of gadolinium contrast that's present within a specific area. So this is how we do our what we call our delayed enhancement or viability or scar imaging, is because there's an inherent property of infarcts and scars that they hold on to gadolinium. And the reason for it, we can go into, it has to do with the volume of distribution of gadolinium. But just kind of know that in a normal myocardium, there's less gadolinium than there is in an infarct or scar if I administer gadolinium and I wait 5 or 10 minutes. And as a result, then, the T1 value for that infarcted area is going to be shorter. So if I do a T1 weighted acquisition that's designed to say anything, the shorter the T1, the brighter the image, my infarct looks bright. What do we need to be concerned about with gadolinium? I think there's 3 things you want to be aware of. One is acute allergic reaction. So with anything that you give a patient, if they're allergic to it, don't give it to them again, right? I mean, I love it, the package insert for all these drugs say, don't take this medication if you're allergic to it. Well, of course. So if a patient's allergic to gadolinium, you would not give them. Now that's different though than, again, the iodinated contrast, right? Gadolinium is a different contrast agent altogether. The second is there was a concern about a condition called nephrogenic systemic fibrosis. I'll go through that, talk about that in a little bit. And then a question about gadolinium deposition. We'll touch on that a little bit as well. So this is right here is an example. First case was described in 1997. Where a person had kind of a systemic sclerosis type fibrosing condition in the skin. What they noticed when they first started seeing these cases was it seemed to be associated with people who have advanced renal failure. Over the years, we've gone through and gotten a better understanding on when this occurs, and there seems to be 2 kind of key things. One is the amount of gadolinium that you give. Right? So it seems to be more of an issue in renal failure patients than non-renal failure patients. And so if you give them a very high amounts of gadolinium, you may be more likely to run into this problem. Now again, this is a problem that's not a 1% problem, not a 0.01% problem, but a 0.0001%, right? I mean, it's a small number of patients out of millions of patients that get scanned. So one is, in patients with renal failure, we're not going to use high doses of gadolinium like we used to. Because in the past, we used to think, oh, gadolinium is safe because it doesn't affect the kidney specifically. So when somebody's got renal failure, they can't get the iodinated contrast, we'll give them gadolinium. And oftentimes they're getting multiple exams done the same day with multiple doses of gadolinium. The other thing is also that the gadolinium itself is generally bound to a protein. And the contrast agents differ in exactly how the protein is bound to the gadolinium. So there's what we call linear binding, where there's a gadolinium molecule and it's just attached to the side almost like this, where there's a linear protein and a gadolinium that sits next to it, or cyclic or macrocyclic, where you have a gadolinium molecule that's completely surrounded, it's like it's in a cage, by protein. And what we've learned also now is that the cyclic or the macrocyclic agents are the ones where it's less likely the gadolinium can separate away. And so now we primarily use these macrocyclic agents. So part of it is the field has learned not to use high doses in renal failure patients. And secondly, to use more of the macrocyclic agents where there's less of a chance that the gadolinium can separate away from the protein. And so I think with that, with the understanding of gadolinium over about a 10-year period of time, we've gone from kind of saying, okay, renal failure patients, maybe we don't want to give them gadolinium, to really kind of saying that use these specific group 2 agents, use them in a low dose. And with that, even patients with renal failure, CKD stage 4 or 5 even, can safely get gadolinium contrast. And the consensus from the American College of Radiology really is that you should not withhold a gadolinium exam for renal failure patients any longer. And also that there's not really a specific need to do dialysis immediately after the gadolinium administration. So you just give them dialysis like they would normally get it. So to some extent, as we've learned more, just like, for example, contrast echo or contrast agents with the ultrasound lab, as we learn more, we can broaden the indications again. And so now really there's not any specific limitation to gadolinium administration with renal failure. Okay, we do have an alternative agent that we utilize. Obviously this came about, when I first came here in 2008, the vascular surgeons were like, oh yeah, we love these MRAs, these are great quality, but as all this NSF stuff started coming out, we said, well, at that time we were not doing patients with renal failure, so they're like, well, what are we gonna do with these patients? So we came up with a way where we use an iron-based agent, which obviously we know iron, there's not an issue of the safety issue that we have with gadolinium, or we were concerned about gadolinium at the time. But this iron agent has similar magnetic properties, like gadolinium contrast. And so we can do an MRA with this iron-based agent. So now, it doesn't have the excellular property, so you can't do the scar imaging or the viability imaging like you can with gadolinium. But for first-pass imaging, like an MRA, this iron-based agent works very well also. So again, this is kind of a little bit of an overview of the basic physics, of kind of some of the clinical nuances that we need to be aware of. And then obviously what we're going to do over the course of the year is really go through the individual different applications where you use cardiac MRI and really kind of talk about what are the strengths and limitations, how does it compare to other modalities, right? To really help you guys in the end be able to say, how can I, even if I'm not going to be an MRI practitioner, I'm going to have to be able to know how to use this in my practice. And how can I incorporate this into my practice? What are scenarios where I would think about using it? That's what we're going to do over the course of the next year to 2 years. So with that, I thank you for your attention, and I'll be glad if there's any questions to answer. And if not, then we'll adjourn and we'll regroup again next week. Thank you for your attention.